My name is Jill Rockweisel. I'm the chair of the department, and I want to welcome you to the Department of Psychiatry Grand Rounds. I would like to welcome everyone from the department, faculty, staff, and trainees, as well as any faculty from other departments. We're excited to have you with us. Just a few housekeeping details. A friendly reminder to please keep yourself muted to avoid unnecessary feedback, echo, and confusion. This presentation will be recorded and will be able to be reviewed, found on our department website, along with all of our FY 2020 Grand Rounds on the under the Research tab. Our presenters will take questions at the end of the presentation to allow for smooth recording. And also feel free to use the chat to enter questions as they go along, and they will be addressed at the end. So I am very pleased and honored to introduce our esteemed panel of department faculty presenters today. A collection of incredible talent and creative minds, I feel certain you'll find today's talk engaging and informative about EpiNet, Early Psychosis Intervention Network. In alphabetical order, I will begin to introduce our speakers. Dr. Melanie Bennett is professor and director of the Division of Psychiatric Services Research. She conducts practice-based research to test and implement services that improve health, enhance community functioning, and support mental health recovery for individuals living with serious mental illness. The possibility of changing the trajectory for serious mental illness is what enticed Dr. Bennett into working with young adults and in helping to build the evidence base for coordinated specialty care. Dr. Robert Buchanan is a professor of psychiatry and director of our Maryland Psychiatric Research Center. His interests in research at the Maryland Research Center have long been steeped in neurobehavioral and neuroanatomical investigation of the pathophysiology of schizophrenia and the investigation of novel treatment approaches for persons with schizophrenia as well. His interest in negative symptoms of schizophrenia have led to a variety of investigations in understanding the mechanisms and treatment of these symptoms. His successful leadership in establishing the Maryland Early Intervention Program is highly relevant to today's presentation. Dr. Howard Goldman, professor on our faculty since 1985, and currently in the Division of Psychiatric Research, is often also the co-chair of the EpiNet National Program Steering Committee. Dr. Goldman's work is as a mental health policy researcher and the principal investigator for the Behavioral Health Systems Improvement Collaborative for the Maryland Behavioral Health Administration. He is the emeritus editor of Psychiatric Services and was on the editorial board of the American Journal of Psychiatry. Dr. Goldman served as the senior scientific editor for the Surgeon General's report on mental health and was elected to membership in the National Academy of Medicine in 2004. Dr. Julie Kreyenbuhl is a professor in the Division of Psychiatric Services Research and the associate director of the Research Core for the VA Vision 5, Mental Illness Research Education and Clinical Center, which we refer to as the MIRAC. Her research interests are evident through her work as PI on the second update of the schizophrenia port treatment recommendations, as co-investigator on the RAISE Implementation and Evaluation Center study. And for those of you that aren't familiar with the acronym RAISE, it stands for Recovery After Initial Schizophrenic Episode. And she's also a co-investigator on the new Early Psychosis Intervention Network, EpiNet, project in DPSR. And our fifth presenter is Dr. Alicia Lucksted, an associate professor, research investigator, and qualitative methods expert with the Division of Psychiatric Services Research. Two areas of interest relevant to today's presentation include her long line of research regarding client and patient experiences with mental health services and how to improve them, as well as a long history of work in creating and improving interventions for serious mental illness, both of which translate quite nicely into her recent focus on the first episode psychosis treatment. So please join me in welcoming this dynamic and expert team in their presentation of creating a learning health system to implement, study, and improve first episode psychosis services.
Great, thank you, Jill. That was a very nice introduction, and welcome everybody to our talk. Before I start, everybody can hear me? Yes? No echo? Okay, good. Hopefully that bodes well. The next 90 minutes. We're looking forward to telling you about the work being done in the department focused on improving services for first episode psychosis. We have our learning objectives listed here. Just so everybody knows, you can see our agenda. So here I am with our introductions. Howard will follow me. He's going to help us learn the background of early psychosis services research and the policy factors that led to its growth in the United States. Just to note that he has to cut out a little bit early, so all your questions in the chat for Howard will get to him, believe me, and he will enjoy answering them, but at a later date. After Howard, Julie and Alicia will talk about the role investigators in our department played in a large National Institute of Mental Health initiative to study interventions for first episode psychosis. And Bob and I will then describe our efforts to develop a learning health system in our state, and most recently, join with a national effort. At the start of our talk, I think it's important to understand just how broad and deep this effort runs within our department. So on this slide, I tried to list everyone who has contributed to all of this work since its beginning, which has been a very long time. While it's hard to see all the names, you can see that there are lots of people listed here, all of whom have made important contributions to this effort. This work involves people across divisions and centers throughout our department. There are researchers focused on understanding early psychosis and other researchers focused on treating it, clinicians who provide early intervention services in inpatient and outpatient settings, evidence-based practice trainers and consultants, data engineers, research staff who collect data, people who manage and analyze it. So we were excited to present, both because we're excited about the work, but also because it really represents so many people and parts of our department. So I'm going to turn it to Howard to lead us off with some overview and context.
Thanks, Melanie, and thanks, Jill, for the introduction. You know, it's really kind of a happy coincidence that on the date of the investiture of our new chair, Barack Beisel, we're giving a talk about how terrific our department is, and particularly how we collaborate amongst divisions within the department. And it's about collaboration between the research community and the clinical services community as well. My job is to provide some historical context and some background. A number of the things that I'm going to introduce as context will be discussed in more detail by the people that follow me in the presentations. My talk really goes back about 25 years, but it focuses on two threads in our department that even precede those 25 years. One thread is the research and clinical practice work on schizophrenia and schizophrenia spectrum disorders, for which our department has been distinguished for a very long time. And the second is services research and the work on evidence-based practices and their implementation, both with schizophrenia spectrum disorders, but more broadly with severe mental illnesses of all kinds. One of the very first activities that brought us together as a cross-divisional, within department activity came about when we bid on a government contract to do a schizophrenia patient outcomes research team project. It involved work with our Center for Mental Health Services Research, which subsequently became the Division of Psychiatric Services Research, the Maryland Psychiatric Research Center, and our colleagues across town at the School of Public Health at Hopkins. It was Dave's, it was a collaborative effort. with Don Steinlocks and Tony Lehman providing a lot of leadership, and then Lisa Dixon became a key part of that project as well. The project involved reviewing the literature, the extensive literature on schizophrenia treatment to know about patient outcomes and what were effective treatments. It developed a series of recommendations based on that review of the literature, but it also had, importantly, a piece related to dissemination and implementation of these recommendations. And a team of us from the department, plus Beth McGlynn, who is a leading expert from the RAND Corporation, we traveled around the country and taught about those treatment recommendations. It was a chance at the time for Bob Buchanan and Julie Kreyenbuhl and Betty Stewart and I to get to know each other and work in a collaborative way in various states around the country to teach these patient outcome research recommendations. When that project was winding down, we actually then got involved as a department in the development of the Surgeon General's report on mental health. And one of the main findings of that report was the gap between research and practice. And that stimulated in a number of settings activities that were designed to improve the implementation of evidence-based practice. And there was structural support provided by the Robert Wood Johnson Foundation and by SAMHSA to develop toolkits, and the so-called Toolkit Evidence-Based Practice Project was born that way. I did want to mention that Alicia Lucksted and Julie Kreyenbuhl and Lisa Dixon were very involved in the development of the segments of the Surgeon General's report that related to schizophrenia, and it was building on the expertise that had been developed in the schizophrenia port and led to subsequent contracts to revise those recommendations further. The National Evidence-Based Practices Project got going with, as I said, with foundation and government support, and Maryland became an early innovator in adopting those practices. It started using the toolkits. Oscar Morgan was the director of what was then the Mental Hygiene Administration, and he encouraged us to get involved in this project that led to the implementation of practices like assertive community treatment, supported employment using the individual placement and support model, multifamily group psychoeducation, co-occurring disorder treatment, using the toolkits, and the state created for us within our department what became the Behavioral Health Systems Improvement Collaborative, or what we know in our division as Center South. I know a number of my colleagues from the collaborative are here in the audience today. We are involved in evidence-based practice implementation, both through our training center, our evidence-based practice implementation center, and the systems evaluation center, dividing up work on making sure that the services are provided with fidelity, and also that training and support are provided. That work has expanded as we as a department have gotten more and more involved in early intervention with psychosis, both through the Maryland Early Intervention Program, which Bob Buchanan will talk about later in this presentation, and also in our work supporting the new sites that have been developed to do first episode psychosis. As a policy researcher working in this area, I'm frequently asked a question that really has been vexing to people. As you'll see when Julie talks about the patient outcome research team, early on there were only a few recommendations related to early psychosis. But over the past 25 years, from work done particularly in Australia, in Denmark, in the UK, and other places around Canada, other places around the world, an evidence base was growing to support a multi-component intervention for early intervention in psychosis. And people wanted to know, well, why has the United States, or was it at the time, so slow in getting involved in early intervention when all this work was going on elsewhere? And it occurred to me that it was at the heart of how we had changed our public mental health system. that in fact, in the late 70s and early 80s, we shifted the focus in our mental health system from ideas of early intervention to focusing mostly on people who were already disabled by mental illness. And then we designed a system whose principal financing and fuel for the service delivery was predicated on the idea that our service users would already be on disability, receiving mostly SSI, supplemental security income, and thereby would have Medicaid. And the system over time grew to be a Medicaid-driven system. And the highest priorities were not the people in the early stages of their illness, but were the people who already had established a pattern of disabling illness. Well, that was about to change as the first decade of the 21st century moved on. The evidence base had gotten quite strong, and the National Institute of Mental Health was determined, particularly in the person of Bob Heinsohn, who remains an active force in the AppyNet movement, to start the RAISE project. And as Jill said, that's recovery after an initial schizophrenia episode. That's the acronym that's used. And it was funded in an interesting way. This is a little policy information that very few people really pay attention to, probably for good reason. But the RAISE legislation was actually part of the TARP bailout legislation from the financial collapse. It actually is attached to the Troubled Assets Relief Program, the TARP. And what also is not well known is that so is the Mental Health Parity and Addictions Equity Act. They were all rolled up in this one piece of legislation. And RAISE was represented as one of the shovel-ready projects that could go forward. And in fact, we bid on the announcement as a department working with Westat and New York State. And we were successful in getting one of the two projects in the NIMH RAISE initiative. The other group was John Kane and Delbert Robinson in New York. And we were both developing the study design. And as the TARP resources declined, NIMH was not able to fund two experiments. And so they decided to divide the two projects in each in half. And the Kane group became the early treatment program. They did an experimental study in multiple sites around the country. And we in Maryland and New York were asked to do what became known as the implementation and evaluation study. And in a way, this relates back to the introductory remarks that I made about our expertise in service implementation and supports. We conducted an observational study in two sites in Maryland, one in Maryland and one in New York. And we followed people who were in the multi-element intervention called coordinated specialty care. We followed them, but in particular, we were asked to focus on supports for implementation, and a whole series of supporting materials were developed here in our side of the RAISE initiative. And that more or less sets the stage, with one exception. If RAISE was fueled by the TARP legislation, the expansion of coordinated specialty care has been moved forward by some unfortunate occurrences in the country that were associated with early onset of psychosis, and that is the series of school shootings. That made legislators sit up and notice, and they attributed the problem, probably incorrectly, to early onset of psychosis that was unrecognized and undertreated. But to the benefit of the field, they created an expansion of the block grant, which led to the ability for states to finance both training programs and, importantly, service delivery programs in first episode psychosis work. So that sets the stage both for the departmental involvement in schizophrenia spectrum disorders, our involvement very intensely in evidence-based practices implementation, our involvement in treatment recommendations, and the design of those evidence-based practices, and sets the stage for our work in first episode Psychosis. So to go over some of the details, I'm going to turn this over to Julie Kreyenbuhl, who'll go over a few of the things that I mentioned in more detail and carry on for the rest of the presentation. Thanks very much.
Thank you, Howard. So as he indicated in this next section, Alicia and I are going to expand on his overview to describe the department's contributions to research on the development and dissemination of evidence-based practices for first episode psychosis that now make up what is referred to as coordinated specialty care in the US. Next slide. As Howard indicated, this all really began with the schizophrenia port study that was awarded to our own Tony Lehman and Don Steinwachs from Johns Hopkins in the early 90s. The schizophrenia port was one of 14 projects. It was the first one to address a mental illness. It was funded by the agency that's now known as the Agency for Healthcare Research and Quality. And this research was motivated by the fact that, at least up to that time, many treatment decisions in medicine were made without any systematic input from scientific data or efficacy or effectiveness, if you can believe that. And so one of the major activities of the reports was to identify and promote the adoption of those treatments supported by substantial scientific evidence through the development and dissemination of treatment recommendations to ultimately improve the quality of medical and mental health care. And so treatments for schizophrenia for which the evidence was sufficiently strong to merit a recommendation were those that were supported by at least 3 well-designed randomized controlled trials performed by independent research groups. And so there have been 3 sets of schizophrenia port treatment recommendations. The first were published in 1998, and these were then updated in 2003 and then again in 2009. Their reach have been substantial, having been cited in the scientific literature over 4,500 times, and also serving as the basis for deciding which treatments for schizophrenia have been supported by many public mental health systems and other healthcare systems in the US and abroad. Next slide. The schizophrenia port treatment recommendations were the result of a substantial collaborative effort from both within the department and across schools on our campus, including the School of Pharmacy. From our own department, both faculty and trainees, representing our division, DPSR, the Maryland Psychiatric Research Center, the Center for the Behavioral Treatment of Schizophrenia, and the VISM-5 MIREC, all worked laboriously on a huge effort to identify and review the vast literature on both the psychopharmacologic and psychosocial interventions for schizophrenia. Next slide. Both types of treatments that met our standards for recommendation status from our last update are included on this slide. I'm not going to review all of them, but I put this here to note that while there was sufficient evidence at that time to support a specific recommendation on antipsychotic treatment for first episode schizophrenia, we were unable to recommend any single or combined psychosocial intervention for this group. And Howard talked about why this was true. While there had been a fair amount of research conducted in Denmark and the UK and in Norway and eventually in Australia, and they had made great strides in demonstrating the effectiveness of comprehensive early intervention services, the US had lagged behind in conducting similar research and in developing the clinical and policy context to launch these kinds of programs. So next slide. And so in 2008, NIMH launched the Recovery After an Initial Schizophrenia Episode, or RAISE project, as Howard has already talked about. It funded 2 studies examining ways to implement first episode psychosis early intervention services. The first one, the RAISE Early Treatment Program Study, was the one led by John Kane and others in New York. And they were the ones who were able to conduct the randomized controlled trial of the NAVIGATE program, that's what they called it, in which they trained clinical teams at 17 sites across the US to deliver 4 manualized interventions. They were psychopharmacology, resilience therapy, family psychoeducation, and supported employment. So that was their model. And after up to 2 years of treatment, patients who were assigned to navigate they remained in treatment longer. They experienced greater improvements in quality of life and in positive, negative, and depressive symptoms. And they had greater involvement in both work and school compared to those in their comparison condition, which was usual care. Of note, the investigators found that those in the navigate condition who had a duration of untreated psychosis, or DUP, of less than 74 weeks had greater improvements in quality of life and in psychopathology compared to those in the comparison condition and compared to those who had a longer duration of untreated psychosis, just underscoring the importance of providing these treatments as early as possible in the disease course. Next slide. So our study was called the RAISE Implementation and Evaluation Study. It was led by Alicia Dixon, but many of us, all of us today were co-investigators, and many others were co-investigators on this large project. It evaluated the implementation and impact of what was called the Connection Program model, which at that time involved clinical teams comprised of a team leader, an individual placement and support worker, a recovery coach, and a psychiatrist who provided a multi-component intervention, both in the clinic and in the community, to 25 to 30 individuals with first episode psychosis. The specific components of the Connection Program model are listed on this slide. They were all derived in part or in full from the Schizophrenia Port treatment recommendations, but they included medication treatment, supported employment and education, family psychoeducation, skills training based on CBT methods, substance abuse treatment, and suicide prevention. And as Howard indicated, the study was conducted at 2 sites, one here in Baltimore, one in New York City, and it was conducted between 2011 and 2013. Next slide. We weren't able to conduct the randomized controlled trial that we wanted to, so this was an uncontrolled study. However, we were able to evaluate changes in the primary outcomes of social and occupational functioning and symptoms over up to 2 years of treatment with the RAISE Connection model in 65 people with first episode psychosis. And consistent with what the Navigate study found, the RAISE Connection program was shown to be associated with significant improvements in social and occupational functioning, as well as improvements or reductions in psychotic symptoms. And some secondary analyses, we found that the cognitive measure of processing speed was identified as a significant moderator of improvement in occupational functioning, while fidelity to the model, engagement in treatment, and family involvement were found to be significant moderators of improvements in both occupational and social functioning. Next slide. So as I noted, one component of the Connection Program model was medication treatment. And with the port as our inspiration, Bob Buchanan and I, along with Joe McAvoy, developed a manualized antipsychotic schedule, it's listed here on the slide, to guide psychiatrists' antipsychotic medication management. We trained and provided ongoing consultation on these recommendations to the psychiatrists in the study, one of which was our own Ann Hackman at the time. She was also a co-author on the paper that we wrote up to describe our experience in implementing this antipsychotic schedule. And one main point I wanted to make about our philosophy about antipsychotic treatment or medication treatment in general, as a part of the Connection program, was that the expectation to use shared decision-making in terms of treatment decisions, whether that be the decision to take an antipsychotic medication or which antipsychotic medication to take, that shared decision-making should be used to guide those treatment decisions. In the Connection Plan model, no one was expected to take antipsychotic medications. It was not a requirement of being in treatment. But what we did encourage was there to be open and periodic discussions about preferences for treatment over time, which can change. And so the schedule itself is listed on this slide. The medications that we recommended as first-line treatment options were those that we know were shown to be effective in reducing symptoms in people with first episode psychosis. We also selected those that we felt had the lowest propensity for causing neurologic and metabolic side effects. We provided both oral and long-acting injectable medications as first-line options. And while a very effective antipsychotic medication, we only recommended olanzapine be a second-line agent because of its propensity for causing weight gain and other metabolic side effects. And we also, it's not listed here, but we also did recommend that if people had persistent psychotic symptoms after 2 or more trials of these agents, that they could be offered a trial of clozapine. Next slide. So over the 2 years of the RAISE study, 92% of individuals were prescribed an antipsychotic medication at least once. They received the medication over the majority of the time that they were in the program. 77% were prescribed at least one of our first-line agents that we recommended. 20% did receive olanzapine, and actually 10% had at least one clozapine trial during those 2 years. 22% received antipsychotic polypharmacy, which is something that is not recommended in our schedule, but nevertheless happens sometimes when people are not, when their symptoms are not resolving. And then finally, in terms of monitoring for metabolic side effects, we found that the vast majority of people had their weight measured at least one time over the treatment period. 72% had their blood glucose measured, and 62% had their lipids measured at least once during that 2-year period. So from all of this, we concluded that our training and ongoing clinical supervision of psychiatrists, which again included supporting strongly the concept of shared decision-making, was successful in our implementing our antipsychotic schedule successfully. So that concludes my presentation. Next step is my colleague Alicia Lucksted, who will present the findings from the qualitative study of engagement in the connection program that she led as a part of RAISE IES. I think you're muted, Alicia.
Of course, the traditional unmuting. Thanks so much, Julie. Right, so just to bring everybody to this point, so RAISE and Navigate, which now are kind of called coordinated specialty care nationally, the model was different. It was a one-stop shop, it was multifaceted, it was early intervention, there was active engagement, a serious shared decision-making, developmentally focused for this particular set of clients and their family, and it showed beneficial outcomes. But another important part of the RAISE IES study, particularly the I part, was the engagement sub-study, because this is crucial for implementing the RAISE model clinically across the country outside of these studies, and subsequently leading to the EpiNet that Melanie's going to talk about, and other things that Bob will. So engaging, meaning engaging clients and their families so they can benefit from this model and the services at a very hard time for, these individuals and their families, both wanting assistance and also being dismayed, sometimes traumatized to find themselves experiencing psychosis, whether or not they even give it that label, and often running into stigma, running into worries about the future, not to mention all their other life challenges. So if a program is not engaging, both initially and retaining people, then they can't benefit from it. Go ahead, please, Melanie. The methodology of the qualitative sub-study was remarkable. I won't go into a lot of details, but remarkable because we were able to gather information from 5 different viewpoints. There was not just the clients and the family members, but also the clinicians for their own experiences and what they observed of client and family engagement, administrators in the systems hosting the RAISE teams, and referrers, which of course is a really important part of engagement as well. These were semi-structured interviews at various time points, and addressed what you would expect: barriers, facilitators, eroders of engagement, and issues that might not fit into any of those categories from all these different angles. Go ahead. I'm happy to talk about methodology and analysis details when anybody's interested, but it seems it's more important to draw the results, the themes forward for this project. For this, presentation. So I've distilled all of those from the previous slide into 6 overarching themes here about engagement. And just to note them really briefly, I'm going to expand upon 2 to kind of illustrate a point here, but they will sound familiar because they are elements, what people found, what families and what the individual clients found engaging, and what clinicians observed people found engaging were the elements of the model that were notable and different, as Julie and Howard described. So that engagement, interactions with staff must be active and warm and non-judgmental and ongoing. That client and life goals and values must be central to engagement and to the services. Think about this developmentally, particularly, life goals are important to everybody at every life stage, but particularly with these young and emerging adults and development and autonomy. The tenor of the services were incredibly important to engagement. Do the clients and their family members feel listened to, accepted, respected? And was the treatment able to be truly individualized? Did people feel like it was responsive to where they were at and flexible? There's also a big emphasis on practical factors and some really interesting nuances about things about location and transportation and other such kind of pragmatic things that interacted deeply with people's struggles with their illness and their life situation. And then from the outside, referrers were consistent in saying that they too had a difficult time sometimes connecting with this new service or this new model, just as clients did and families did, finding them and then knowing how to get in, that referral processes must be clear and responsive and prompt, especially when you're kind of a new kid on the block. So we can go to the next one, please. I want to address 2 of those themes in a little bit more depth because they illustrate how important it's been to carry this philosophy through into the national implementation. First, the addressing of client life goals. So not only symptom reduction and stability, of course, those are important, but to sincerely have a program that could help clients get on their way as this, I think it's the first quote says, to get rolling again was really important to families and clients feeling like this was a program that can serve my health needs and was worth attending, which was not necessarily easy for them. So it was a very central part to engagement. You can go to the next one, please. Families and clinicians saw this too, and they tied it to the diverse and flexible, coordinated team that provide the services, because that's the team that could be responsive and flexible to the client's current situation, as the one quote says, and life goals. And to promote attention to the whole person across the psychiatric services that were provided. I think, sorry, you can go on. The second one is just to amplify something that Julie mentioned already, that one key element of the RAISE model is truly shared decision-making. So the tenor of relationship and interactions between clients and families with the clinical staff was really crucial to them for wanting to come back. You know, time and again, people said that they felt like the team actually cared and was competent, that combination, with a multifaceted respect that was reflected in this practice of shared decision-making. Not just a static sort of like informed consent, but an ongoing dynamic shared decision-making. And on the next slide, there's a couple of clear examples of a clinician talking about sharing review articles about, I believe this was about, about medication with a client and her mom. I'm sure it's something many of you have done at different times, but for that to be the norm. And the quote at the top what sort of exemplifies the goal of shared decision making, that people come to their own conclusions that are best for their own health. So medication discussions were particularly acute and important. Sorry, shared decision making was particularly acute and important for medication discussions. And all of this, sorry, you can go on, please. And all of this was really important, really adds up to engagement being optimized when teams were able to create a program and setting that really delivers the model as it was created. Highly individualized, recovery focused, active, non-judgmental, all those things we've been talking about. Giving a hopeful message overtly and subtly that recovery is possible, getting one's life back on track to a brighter future is not only possible but likely. And that is overall the conclusions of the engagement sub-study, that the model is indeed different than what most people, unfortunately, were getting, and I say are still getting, in general mental health too much of the time, and that the unique aspects of this model were really important to its outcomes and also to people being present to actually receive those outcomes, to engagement. So this reified the idea of the model and that it was necessary to implement it as we carried forward coordinated specialty care nationally. And oops. So these ideas are baked into the various resources that were created to do that. These are just examples of the models, of the manuals for the different coordinated specialty care programs, and from Maryland and New York, but have also been distributed nationally or used nationally. The moving of the RAISE, IES, and the Navigate into national implementation in a services way also heralded the development of different support networks and structures for them, such as the Maryland Early Intervention Program, which Bob will talk about next.
Thank you, Alicia, and thank you, Jill, for your introduction. I'm going to be providing a relatively brief overview of the Maryland Early Intervention Program, or the Maryland EIP. And I'd like to start off by first stressing that this is a collaborative effort among 4 different organizations: the University of Maryland School of Medicine, as represented by the Department of Psychiatry, the Maryland Psychiatric Research Center, and multiple divisions within the Department of Psychiatry, UMSOM, University of Maryland, Baltimore County, and the Maryland Department of Health, Behavioral Health Administration. Next slide. Thank you. So on December 12, 2012, the deadliest elementary school mass shooting in U.S. history occurred at Sandy Hook Elementary School in Newton, Connecticut. Howard had made reference earlier about the impact of these mass shootings on national policy. This particular shooting set off a series of events which culminated in the governor of Maryland, O'Malley, at the time, asking the Secretary of Health, "So what are we going to do to prevent such occurrences happening in the state of Maryland?" This and other questions led us to submit a proposal to the governor through MDH BHA, which was eventually funded through the governor's supplemental budget. We had fortunately been in good position to put together such a proposal rapidly because Tony Lehman, who was chairperson at the time of the shooting, had already asked a number of us to work on a proposal for developing a first episode treatment program, which we quickly translated into a response to the governor's request to submit them a proposal about developing a treatment program for people who had a mental illness with psychosis, a first episode. So our operations began in September 2013, and we are currently funded through a 5-year contract from MDH and BHA. Next slide, please. Our mission can be reflected in these following goals. First, our goal is to reduce chronicity and enhance the likelihood that a person with early signs of psychosis will be able to manage their illness. that they will be able to move successfully through the appropriate development stages of growth, and that they will establish a life of their own choosing. In the context of our formation, we take a broad public health perspective in which we directly address issues of aggression, violence, and substance use. And our goal is to optimize the likelihood of recovery from serious mental illness with psychosis. Next slide, please. The Maryland EIP is a multidisciplinary effort. Maryland EIP leadership is comprised of professionals from multiple disciplines, some of which I will highlight during the rest of the presentation, including health policy experts and leaders from the youth and family advocacy community. We are comprised of 4 service components: outreach and education services, clinical services, consultation services, and training and implementation support services. Research is integrated into each of these components and focuses on the early detection and prediction of disease emergence, treatment development, and recovery. I'll briefly describe one example of this a little bit later on, and Melanie will give a much broader description of EpiNet, the most recent example of research and Maryland EIP collaborations. Next slide. So Howard, I think it was Howard, but it could have been Julie now, made reference earlier to the duration of untreated psychosis, or DUP. Lack of knowledge about mental illnesses with psychosis and their treatments leads to stigma and leads to an increased threshold for seeking treatment. It was actually, yes, I remember now, it was Julie, okay? These factors lead to prolonged duration of untreated psychosis, or DUP. And why this is so important is that, as Julie described in talking about the Navigate study results, the longer the duration of untreated psychosis, the poorer the prognosis, the poorer the treatment response. So that developing services which can lead to a decrease in DUP is one of the critical components of our mission. And one of the ways that we do this is through our outreach and education efforts. The Center for School Mental Health is primarily responsible for our outreach and education efforts. The center is directed by Nancy Lever and Sharon Hoover. We also have considerable amount of support for these efforts from Cindy Schaefer, Lorraine Bernstein, and a slew of other individuals. The approach has 3 different components. The first is to teach providers how to identify signs of clinical high risk and early psychosis. The second is to familiarize providers with relevant assessments and evidence-based practice. And the third is to offer providers ample ways to refer individuals if needed for further consultation and treatment. And before I forget, I just wanted to mention, pick up on one of the points made by Alicia in her presentation, was that one of the things that was important for providers and others was to have an easy way of referring clients to the services. And so one of the components of the Maryland EIP, which we think is a critical component, is that we actually do have a single centralized line that is provided to people to either email us, to call us, or to communicate with us through other means, so that all referrals, all inquiries come in through a single point of entry. The settings for our outreach and education activities include preschool, elementary school, high school, colleges and universities, behavioral health and primary care settings, and advocacy groups. We have made efforts over the last 8 years to try to have greater involvement with local hospitals, ERs, and also with various military establishments throughout the state, given when the typical onset of a first episode of a mental illness with psychosis occurs. Since our inception back in September of 2013, we've held over almost 700 events with approximately 59,000 attendees, so that the outreach and education component has been considerably successful in their efforts. Next slide. In addition to doing in person, which we hope to be able to resume sometime this year, if not next, rather than remote outreach and education trainings, we also have a web page in which we have multiple resources for clinicians, families and friends, clients, schools, and others. Alicia showed you some of the specific type of resources that we have developed, either in collaboration with OnTrack or by ourselves. And we address a full range of services that would be important for the treatment of people with a first episode of psychosis. Next slide. So the second major component is our clinical services, and within that is our third component, consultation services. One of the elements that's really unique about the Maryland EIP as compared to other first episode programs in the United States is that we have integrated into our clinical education and outreach services, both services for people who are at clinical high risk for developing and mental illness with psychosis, as well as first episode psychosis treatment programs. Our clinical high risk program, the Strive for Wellness Clinic, is run by Gloria Reeves and Jason Schiffman from UMBC, and was actually named after one of the people who received a consultation evaluation through our services, commented that the program was designed for them to strive for wellness. And so we used their comment to name the clinic. We currently have 2 first episode psychosis treatment programs, the MPRC First Episode Clinic, which is directed by Elaine Weiner. This is one of the oldest first episode clinic programs in the state of Maryland. And the second is the Raise Connection program, which is directed by Ann Hackman and Jane Richardson. As one might gather from the earlier presentations, we were in a very good place to be able to develop the Maryland EIP and to develop various clinical programs. The Raise Connection program is the descendant of our Raise IES research efforts and has the continuity through Ann Hackman from the period of time when we were doing this as a research project. And we also provide statewide consultation, which I will discuss in a little bit more detail in a moment. All of our clinical services are recovery oriented. They're all designed to help each individual achieve their full potential, whether that's through school activities, employment, or reaching other personal goals. And they all emphasize safety, including extensive risk assessment and safety planning. Next slide, please. So as I mentioned, research is integrated into all of the different components of the Maryland EIP. This is just one example. Our initial proposal for the Maryland EIP, and in particular for people who are at clinical high risk, was to expand our consultation and evaluation services, but we did not have a specific treatment services for these individuals as part of the Maryland EIP. In collaboration with BHA, Jason Schiffman, Gloria Reeves, and others were successfully able to respond to a SAMHSA grant announcement, which was called the Community Programs for Outreach and Intervention with Youth and Young Adults at Clinical High Risk for Psychosis, or CHIRP. And what was good for us was that the funding was able to provide us with resources to enhance our ability to detect people who are at clinical high risk, and more importantly, to be able to begin the development and implementation of specific treatment services for these individuals. In particular, the treatment services are based on an evidence-based step care treatment approach, which is designed to prevent either the conversion to psychosis, or if a person does convert, to try to lessen the severity of a psychotic disorder. Next, please. So ultimately, our goal is to be able to provide services throughout the state. There are a lot of challenges associated with this, including, of course, the actual rate of occurrence of a first episode of psychosis, which limits the type of services we can provide in areas that are less populated, including Western Maryland, Southern Maryland, and the Eastern Shore. So to try to address this gap, one of the things that we have continued and enhanced was our consultation services for people who are experiencing a first episode psychosis. And through our consultation services, we're able to provide diagnostic evaluations, treatment recommendations, and planning to improve school and family functioning. Our consultations have been and hopefully will soon be provided in person, 1 to 3 visits, or via teleconference. And consultation requests have come from schools, colleges, psychiatrists, primary and pediatric care providers, state institutions, and others. And one of the things that I think has been a real success of the Maryland EIP is our establishment of telepsychiatry services with the Midshore Mental Health Services on the Eastern Shore. This activity is directed by Gloria Reeves, and she works in collaboration with Elaine Weiner, Kay Connors, Pamela Rokshan, Jason Schiffman, and Doha Chabani, and others to provide consultations on cases that are referred to us through care providers on the Midshore mental health system. Next, please. So the final component of the Maryland EIP is the training and implementation support component. This is directed by Melanie Bennett and Howard Goldman. Over the past 5 or 8 years, working in collaboration with BHA, we've been able to establish 2 new CSC programs, the Johns Hopkins Epic RAISE program and the On Track Maryland Shepherd Pratt program, which is located in Gaithersburg. Both of these programs are in the broad umbrella of the Maryland EIP, though we don't have direct responsibility for either one of those programs. But what we do provide, or have provided, is training for all the staff at those 2 programs, including the Cs, the Special Employment Education Service Specialists, the psychiatrists, social workers, etc. And we're also working now with BHA to hopefully develop a new program in Prince George County. We provide monthly supervision to all of the providers, both in the CSC programs and within the Maryland EIP proper. And the other aspect of the training and implementation service support component is to create learning opportunities to support collaboration, sharing of resources, and coordination of service delivery. Next slide, please. These are the current CSC programs in Maryland, and for time's sake, I won't go into too much detail about them, as helped along by Melanie just there. And finally, I wanted just to remind people that the Maryland EIP does have a research focus written into it. The primary areas of research are early detection of disease emergence, prediction of illness progress and recovery, and treatment development. Since 2014, we've had 44 NIH, SAMHSA Foundation, and/or state grant and contracts submitted. 29 of these have been funded. And the most recent award that we've received is an R1 from NIMH, connecting FEP research and practice through a learning health system, or EpiNet, for which Melanie Bennett is the PI, and this will serve as my segue to Melanie.
Terrific. Thank you, Bob, and Julie, and Alicia, and Howard. Up until now, Julie and Alicia and Bob have filled you in on our local and state efforts in early psychosis services. And I'm going to return us to the national scene and tell you about our involvement in an initiative to improve early psychosis care across the country. So Thinking back to what Julie and Alicia told us about, the RAISE results showed us that early intervention can help young people who are experiencing a first episode of psychosis. Sadly, what often happens to research, even when it's good, is that it sits and it's shelved and it doesn't impact service delivery at all. But the National Institute of Mental Health wanted to make sure that this did not happen, and they worked hard to make sure that these findings led to implementation. Now that we know that we can help, let's get this to the people who could actually be helped by it. This led to a program of national implementation with dedicated funding and partnerships among federal and state agencies. And if you have not passed out from that sentence, keep listening, because it really is an amazing story. In 2014, Howard alluded to this, Congress increased the Community Mental Health Block Grant, which funds mental health programs to the states. This increase, though, in 2014, if you can believe it, they required that it be used to implement early psychosis programming. So there was an increase with a mandate. It wasn't just a mandate, it was a mandate with actual funding behind it. NIMH worked with SAMHSA to provide resources and technical support to states who needed it. You can already see that we in Maryland were in a good situation here because we had a lot going on. We were the lead, some of the national leaders in developing the coordinated specialty care model, but most states didn't have that kind of work that came before it. So they needed help and they were provided it. In the next few years, there were no increases in funding, but there were mandates. So over the next couple of years, states got the block grant and were told you have to use at least some of this money to further support early psychosis services. And the maps here show what happens when you do that. When you first provide some money and then you say you have to do it, it gets done. And so the 2019 map with all of those circles and stars shows that that is a model that works for implementation. This effort was so noteworthy that it was identified in 2014 by the NIMH director as the single most noteworthy research story of that year. And he wrote in some writings, RAISE reminds us how research can be moved into practice when agencies, Congress, and states are aligned. Actually, the fact that the story doesn't stop there, it increases the remarkability of this. In 2019, the National Institute of Mental Health developed what everybody keeps referring to as EpiNet, the Early Psychosis Intervention Network, a progress focused on learning from the national implementation that I just presented about to further improve services. So it would have been enough to have national implementation and then to coast. But what NIMH decided was this is a great opportunity to learn, to see where we're still falling short, and to improve. So EpiNet includes regional hubs that link coordinated specialty care programs across the United States through the use of standard clinical measures. The data that's collected in each hub will be gathered by a national data coordinating center to create this database that represents programs and clients from across the country. And you can imagine what a great resource this will be that can be used to conduct practice-based research and ultimately to improve care. So this map shows where the hubs are located. The network began in 2019 with 5 regional hubs in Massachusetts, New York, Minnesota, California, and a multi-state hub that included programs in Florida, Michigan, Oklahoma, South Carolina, and Connecticut. And I specifically wanted to state all those states so you can see that they're really trying to create something that reaches a lot of places in the country. In 2020, 3 new regional hubs were added, one in Texas, another multi-state hub that includes several Midwestern states, and the best regional hub of all, representing programs in Maryland and Pennsylvania, which is us. Our hub is called the Connection Learning Healthcare System and represents a network of 20 coordinated specialty care programs in Maryland and Pennsylvania, serving over 500 young adults and their families. And like anything, to get a lot of good stuff going on, you need a lot of collaboration. So this represents a collaboration among 5 institutions across 2 states, us and our School of Medicine, the University of Pittsburgh, the School of Medicine at Penn, Hopkins Medicine, and Public Health, and Shepherd Pratt. So wow. Plus our states both have involvement. Our Maryland BHA partners I have represented through the EIP, and Pennsylvania has a similar state center called Heads Up. Our hub has 3 overarching aims, and I'm going to talk about each of them briefly in upcoming slides. Our first aim was to deploy this common assessment, a common package of assessments across all of these programs, and to develop a way to manage the data that is collected from that. Our second aim is to create a 2-state learning health system that will ultimately improve quality of care. And our third aim is to conduct practice-based research. So looking at what practice questions remain, which there are tons, and really digging in and trying to find some answers to those practice-based questions. Before I go on to that, though, I wanted to present a slide that summarizes a bit about our 20 programs. The blue ones are in Pennsylvania and the red ones are in Maryland. So you can see a little bit about these programs. They are serving clients aged 13 to 35. So young adult and early psychosis can span a large age group. Clients are within 2 years of a first episode of psychosis when they come into each of these programs. We have good representation from small and large programs across urban and suburban and rural settings. Right now, 4 programs serve at least some rural counties. So we're particularly excited by that. We don't have, that's why cross-state collaboration is good. While we aspire to serve rural counties in Maryland, we continue to work on that, but Pennsylvania already had some programs in those areas. All right, so thinking back to our 3 aims, this slide covers aim 1, which is which I show here, components of our assessment that will be collected at intake and every 6 months. We are working through 2 main assessment challenges. One is harmonizing across many places, harmonizing what we collect. And the second challenge is integrating this assessment into clinical practice. So the first, harmonizing what we collect across states and nationally. So we came on board in 2020 and we were handed what the national effort is calling a core assessment battery. So they said, this is what all your programs are going to collect, which is great in many ways and also kind of nerve-wracking in many ways, because what if our programs don't want to collect these things and don't care about them? Also, our programs and our state partners might have things they want to collect. And while researchers think that more is better, programs generally think that more is a headache and a hassle. So harmonizing is taking place across a lot of levels: national, regional, local, programs and researchers and administrators. This has been quite an adventure, but I'm happy to report it's going well. We have a version of an assessment battery that all of our programs have started to implement. Our second challenge has been shifting the way we think about assessment and data. In this project, collecting these assessments is not research that is separate from programs' routine clinical practice. It's just part of what's going on in the programs. So we assist programs in doing this, but it's really up to them to figure out the best way to do it in their local context. Eventually, we will provide sites with tools and customized templates so they can use this information to think through their outcomes and plan treatment for individual clients. So we're collecting a lot of information, and secondary or aligned with that is we have to figure out a system to be able to use that information. So we have developed a data management system that went live thanks to our amazing team just a week ago. Programs can enter information as they are collecting it. Our team has created a system for programs to be able to track who's due for assessments and when they're due and have they been done. Each site collects and uses their own identified data. Our hub aggregates de-identified data across the sites, and then several times a year, we will provide de-identified data to the national database. So all of that was aim 1, if you can believe it. Aim 2 centers on developing a learning health system. So using the data to answer questions and improve practice. We were fortunate that Maryland and Pennsylvania both had elements of learning health systems. Howard and Bob reviewed some of what was already established in Maryland. Howard talked about, we have statewide evidence-based practice implementation for several components of coordinated specialty care, including supported employment and family psychoed. Bob talked about, through the Maryland EIP, providing a structure that brings clinicians and researchers and administrators together to talk about their experiences and hopefully to improve practice. And Pennsylvania has similar sorts of activities going on. So our task now is to, again, harmonize this to create a new 2-state learning health system. And we're doing that now, which is, again, another really interesting piece of this work, and it's progressing. Our general process when we've successfully completed this aim is to identify questions, use data to answer them, use these answers to inform practice changes, and then to pilot those practice changes and see how they do. And I have on the side of the slide how this might work for just a sample question. Who gets a job, right? So we can use our data to look at predictors of who gets a job. Let's suppose the answer to that is people whose social functioning improves. We can then help our programs identify people whose social functioning is not improving, and we can help our programs implement a practice to use with those particular clients. And then we can help think through how to understand that implementation and whether it was useful. The LHS will also be used to identify questions that require additional data collection to answer. As part of our application to be part of EpiNet, we had to propose a specific research project. And at that time, our learning health system wasn't fully functional, but we took a learning health approach to identifying what that project would be. First, we looked to the literature to understand what were the main clinical questions or the main things that really mucked up outcomes. And then we talked to our programs about it. So we got some ideas, and then we went to clinicians and to programs and said, what do you struggle with every day? What are the things that if you could snap your fingers and they would be better, what would those things be? And fortunately for us, we have great program participation. And then we were smart and we just listened. What came together was the fact that marijuana use really is a struggle for our programs. And the data show that it's really predictive of poor outcomes. It was also nice that we had a lot of investigators in our hub who were interested in substance use. So we took all of that to think about how we might target address particular targets to improve how our programs could address marijuana use. And what we decided to do was focus less on that marijuana use per se, but to target engagement in treatment. And we know, again, from the literature that what marijuana use seems to really get at is it leads to poor engagement, poor use of medication, and ultimately treatment dropout. So we said, what if we developed a way to talk about marijuana use that wasn't necessarily landing hard on the marijuana itself, but was really promoting engagement, keeping people in treatment so that we had more time to work with them. They could start to benefit, and then maybe that would help them realize that reducing their marijuana use would be a good idea. So this led us to our research project, in which we are adapting an intervention called the Teen Marijuana Checkup, which is a brief motivational enhancement intervention. You do a little bit of assessment from people and then present that information back to them in a personalized, highly engaging feedback report. I have a few pictures here of what that looks like. And we are going to do some adapting to figure out what kinds of feedback are most compelling to our clients with first episode psychosis. So we're in the midst of collecting data from clients and family members and clinicians about cannabis use, about marijuana use, and how it impacts coordinated specialty care involvement. And eventually we will use that information to make some adaptations. And then eventually after that, we will come up with an adapted intervention and we will pilot it throughout our network in our hub. So, progress to date, we are doing some of all of those things. And we've only been at it for 6 months. So the fact that we have an assessment battery, we have a data management system, our programs are starting to use both of those things. Our learning health system is getting itself together, and we've started our research project, really makes me feel like we're going to get there, which is great. On the other side of the slide, I have a little bit about some of the national EpiNet efforts. So I go to a monthly national meeting of all the PIs of the EpiNet hubs, and we talk about things that that impact coordinated specialty care nationally. These are some of the working groups that are listed here, and we've started talking about questions that are have a lot of interest throughout different hubs and building up teams nationally to start to address them. I think I'm going to just skip that new initiative slide and wrap us up so we have some time for questions. So I hope we have given you a good overview of all of this work and its reach in our department. Coordinated specialty care for first episode psychosis delivers a set of evidence-based services that have been recommended for a long time. From Howard now to me, what you've learned is that the services aren't new. What's really new here is bundling them so that people don't have, especially young people, don't have to go to a lot of different places to get them. And then also new is a shift in how we think about services from towards preventing disability, away from waiting till people are disabled to help, to trying to move services much earlier in the trajectory in an effort to change how things work out. So as our work progresses, I will speak for the team that we look forward to letting you know how it's going, what we're finding, and how things are going. So thank you. And just a shout out to us that we were to end at 1:20, and we have.
So Melanie, you have a few questions in the chat if you want to take a look at them.
Well,
The whole team actually, but.
I can try to take a look at them. Let's see.
Well, I had one, I'll just say it out loud. There was, from the beginning, the services were limited to 2 years with then referral once they completed the 2-year period of time, which I know from the early phases of RACE was very difficult to find appropriate services. So I kind of wonder where that is now and what you might be seeing across EpiNet. Is that still an issue?
So that is a great question and of great national interest. We are talking a lot about post-CSC services. What happens next? Now, this has been addressed differently in different states. Here in Maryland, our programs are providing services, and while I think they really try to limit what they do to 2 years, there are some people that the right next step is just not evident after 2 years. So we have to always be flexible, because really patients and their care is what's the most important thing. Other states have addressed this by funding their programs to create step-down models. Pennsylvania did that, and they have 9 of their 14 programs got a little bit of extra funding and created different models that fit in with what they do and how they're comprised. And so they have different, they have a step down at 9 of their programs, and probably they've just added 5 programs, and I think they're planning to do the same thing there. Nationally, we're starting a work group about CSC, post-CSC services. Actually, there was just a webinar on this, so I will find the link and send that out to people. The webinar was run by somebody who just reviewed this, I guess, the state of the art nationally on post-CSC services, which would be a great place in Maryland and nationally, of course, to start from. What's already happening.
Thank you. You have another question from Mark Ehrenreich. What factors and measures are used to determine who is at high risk for developing psychosis, but who have not yet experienced psychosis? Who is in your high risk group?
Well, I think I will punt that question maybe to Bob.
Okay.
Gloria, Bob.
So largely the most important defining characteristic is probably presentation with symptoms that don't represent full-blown psychotic symptoms, or not full-blown hallucinations, delusions, or thought disorder, but they are what I would call form fruste. The individual hasn't quite decided that these are things that are true or not. There's still some ability to have the individual doubt whether their suspiciousness is reality-based or not, but they're moving towards the direction of developing full-blown symptoms. The other characteristics associated with clinical high risk are a deterioration in social functioning, usually school functioning, since the typical age of onset for people with these symptoms is probably 14 to 18. And if Gloria is on and wants to add anything more, or Alicia, that would be fine too.
No need, we got a couple other things, so.
Yes, so somebody asked that I put up this slide since I had blown by it. So here it is. I can't look, well, I probably can look at the chat while I'm sharing my screen, but I fear that that might blow up in my face.
I don't see any other questions in the chat unless I'm not looking at it right.
Sorry, can I make a quick statement as well?
Please.
Just to mention with what Bob was just going through, DSM-5 in section 2 has the attenuated psychosis syndrome, and it lays out the criteria for identifying that, and that was intended to be used in the clinical high risk. So if you look at your DSM-5 in section 2, you'll find attenuated psychotic symptoms.
Great.
Melanie, I sent the question just to you, not to everyone, so maybe that's why you didn't see it.
Well, you and I will get together and I will answer that.
Well, I can read it out for you if you want.
Okay.
I mean, I have specific questions about cannabis that I'll deal with you separately, yes. So several presenters mentioned the issue of duration of untreated psychosis as an important factor or characteristic. So I wonder if you could briefly address the strength of the evidence relating those two, because how do you rule out factors, a patient characteristic environment that both delay diagnosis and lead to more serious illness? So it's not a true cause-effect relationship.
Well, who on the team would like to take that?
I guess, I mean, I'll say something. I'm not sure.
I'm not-
Alicia, we lost your sound.
Yeah, I don't hear her. I'm sorry.
No. Alicia, we can't hear you.
I guess she can't hear us.
And apparently she can't
Now
hear
we
us.
can't see her.
So David, I think that most of the studies that have been conducted that have looked at the relationship between DUP and poor prognosis have tried to control for variables related to differences in illness severity. I think the one thing that's been particularly difficult and would be consistent with the concern that you're raising is what is the relationship between acute onset versus insidious onset. And we know that insidious onset has been also associated with delays in going to treatment. And so that would be probably the disease variable that would be most confounding in trying to draw a direct link between DUP being an independent variable entirely from the presentation of the illness.
Okay, so excuse my ignorance, but sounds like what you're also saying is the more dramatic the presentation, the more likely you're going to be diagnosed earlier.
Well, I think that would probably be true, yes.
Okay.
It would require a less sophisticated system to be able to pick up on dramatic presentations.
Right. So the difference I thought of was positive versus negative symptoms might be the
Yeah. Yeah, so the other issue, that your question raises, and I wish Alicia would come on because it looks like she's saying so much, is that, oftentimes the initial signs of an impending illness with psychosis is going to be nonspecific, and it's going to be a fall off in social interactions and or school functioning, etc. And part of the problem with those type of things is that it could be just normal development, or it could be due to substance abuse, or it could be due to other disorders or confounding variables. Whereas if you have someone who presents being acutely psychotic, then there's less questions and less issues with the differential diagnosis. You are right that frequently the initial symptom complex in a person who's developing a mental illness with psychosis is negative symptoms, but they would not reach, I don't think, criteria for either CHR or a first episode with psychosis until they begin to experience and evidence positive symptoms.
Thank you.
There's one other question. Why does the coordinated specialty care have to stop at 2 years?
Well, that is a great question. It was conceptualized as early intervention. And way back and with the RAISE research projects, a group of us had to plan out what will be included and how long will it be for. Given that, it developed into a 2-year program.
So it's your fault.
It's a struggle and has to be flexible. And that was really a starting point. And almost immediately, program said, "What are you doing? 2 years, you're killing us here." But we're, now a major interest in research is to figure out, should it be longer? Should it be short? We didn't know at the time. Maybe 2 years was too long. Who knew? So it developed as a 2-year model. And now we're thinking, the research is really following the practice here, because the practice is saying for some people 1 year is enough, and for other people it probably could be 10 years and wouldn't be enough. So we're starting to we're now at a point to be able to wrestle with all of that now.
So I guess one of my questions, Melanie, this is Jill, is you know, at what point should we be, I mean, there has to be a year limit because otherwise it's not early intervention. And then some people just turn into more, I don't want to use the word chronic, but extended course of illness. And then that defeats the purpose of an early intervention. So, and furthermore, if you've got an expensive form of care that has limited funding and you want to serve the most people that meet the criteria, you've got to have some limit. So at what point do, you know, and how, I guess, and I don't expect an answer to this, but I think we should start thinking about, well, how do we expand some of these assessments and interventions into routine community mental health centers? I don't know if that's realistic, but given that it's so difficult to, and you know, the whole issue comes down to getting reimbursed for services. That's what it comes down to. Some of the valuable implementation of some of the valuable interventions aren't reimbursable under a standard community mental health model. But it just seems to me, as I was listening to all of you talk, that there are very valuable assessments and standards of care that probably should be introduced more broadly.
And I would encourage everybody to read Howard's paper. I can get that out to people too, where he thinks about just that. Like, this is a great model, and maybe it's the model for mental health services. And how do we think that through?
Well, it is 1:33, and this has been a wonderful, wonderful presentation. I want to thank each and every one of you for your presentations and information. This has been great. I do invite people to take yourself off mute and give our panel of experts an applause. So just a reminder that you can review this or forward it to someone else. And the recorded presentation will be up on our website under resource tab, probably within a week. Thank you again, and thanks everyone for attending. A great turnout. Bye-bye.
Bye-bye.